Hello there, I'm Mitchell Warren, the Executive Director of AVAC, an HIV Prevention Advocacy Organization, and I'm delighted to welcome three colleagues here today to talk about HIV prevention and research here, particularly in the United States, with three officials from different agencies across the United States. And I'm delighted to welcome Dawn Fukuda, who directs HIV and AIDS in the state of Massachusetts, Carl Diefenbach, who directs the Division of AIDS at the National Institutes of Allergies and Infectious Diseases at NIH, and John Smith from the Centers for Disease Control and Prevention, who's really been at the vanguard of many things, particularly oral PrEP here in the United States. We're going to spend the next little while talking about what is happening here at CROI and more broadly what's happening in the United States, in particular with the AIDS response. So I'm delighted to welcome you all this morning. Maybe I'll just start, given that we're here in Boston at the Retrovirus Conference, just to get a sense of what is either exciting you or interesting to you or keeping you up at night or getting you up early in the morning here at CROI 2016. John, do you want to start?
Yes, well, as usual, we've had a lot of really interesting presentations and more to come later this week about pre-exposure prophylaxis for prevention, which is one of the areas in which I work most. There's been good data confirming safety in young people, safety for bone health, some other things where we thought that was the case, but it's always nice to see more data showing that. I would say that there's a very concerning finding that's reported here, and that is there was a very interesting analysis of the lifetime risk of acquiring HIV. And the lifetime risk for black men is 1 in 2 will acquire HIV at some point in their life unless we do something about it, more than we've already done. It's not like we haven't been working on this, but what we're doing isn't enough, apparently. And at the same time, there are several presentations showing that although PrEP is increasingly being adopted and delivered in lots of clinics and lots of places, that a uniform finding is the inability to locate and provide PrEP to high-risk black MSM. So on the one hand, we know that the risk is extreme, and on the other hand, we're learning from various presentations that we don't know how to deliver PrEP to that population.
Carl?
One of the really interesting sets of new data coming out are new innovations in pre-exposure prophylaxis. We saw data yesterday on injectable cabotegravir and injectable rilpivirine being used as therapy. As we go forward, can particularly injectable cabotegravir be used in both men and women as pre-exposure prophylaxis? So that's an area to come. The other area is both interesting and vexing at some level is the ability of the rings. In the case of the dapivirine ring that's reported from both the ASPIRE trial and the International Partnership for Microbicide trials, is that it worked reasonably well in older women. And older here is an interesting definition, it's over 25. But in younger women, 25 and under, it doesn't seem to have any activity. And whether that activity is solely due to lack of use, adherence, or whether there's something else going on there is not at all clear. There's no data. So in that sense, it's a mixed bag, and how we sort that out and make it useful. Now again, coming back to Dawn's point about being able to get to delivery of pre-exposure prophylaxis, I think we're going to continue to see the evolution of PrEP, and it's not going to be fast enough for most of us to really have the impact we'd like to see, but hopefully eventually both domestically and internationally we'll get to a point where PrEP will be part of our armamentarium.
Great. And Dawn?
And I agree with the points that Dawn and Carl both made. I thought what I was struck by, particularly in the lifetime HIV acquisition risk, as well as the survival analyses that were done that show a 13-year difference in survival between people who are HIV negative and HIV positive, and that there were disparities in there, not just by race, ethnicity, but by geography. And so the epidemic, and we're hearing it more and more at CROI, continues to be characterized by profound health disparities, and access to PrEP is one that I'm particularly concerned about in states where Medicaid has not expanded, for example, where healthcare reforms have not been implemented, where those medications and those interventions are less likely to be third-party reimbursed. We're going to see an exacerbation of disparities, particularly for the most low-income individuals. So that's from a policy perspective something that we want to pay attention to here in Massachusetts, but I know nationally as well.
Sure. One of the things that's so striking when I look back over the last 5 or 6 years is kind kind of the oral PrEP story at CROI and just generally, and clearly the cascade of research results, and this pace of implementation, and it is quite variable. And I'd be interested, there was a great session yesterday, actually, Dawn, you were one of the conveners of looking at some issues related to PrEP and its rollout, and a lot of talk about early adopters, and we certainly have a growing base of that now over 5 or 6 years. Do you have a sense of what are those lessons, and I think particularly from the CDC and even from the state of Massachusetts, what are are we learning enough that you can begin to tell other states or other municipalities or other countries, what are we doing, what should we be doing differently or better in terms of lessons about oral PrEP?
I think we've learned some important lessons. I think that the early adopters in terms of providers have been the HIV care experienced providers. However, many of them have their hands full taking care of HIV positive people, and so there's not capacity for them to be providing PrEP to all the negatives for whom it may be indicated. We've also learned that we haven't struck the right tone or message or way of delivering the information to primary care providers to engage them in large enough numbers to meet the growing demand, because in the last year or two, there have been marked increases in demand for pre-exposure prophylaxis. So I think some states are starting programs that are specifically targeted to do that, and there are beginning to be ways to share that information across states and across jurisdictions. I think the other place where, if you think of the early adopter as the user, I think we have done a good job with MSM, who are very linked into sort of HIV advocacy and the HIV community. They knew about PrEP, they were ready to start it immediately when it was approved, et cetera. But for minority MSM, for MSM who are not necessarily linked into those advocacy communities, we haven't really learned yet how to let them know that this is available and how to get it and what it's for. And again, I think health departments are taking the lead in actually figuring out what kinds of campaigns and outreach is going to work in those jurisdictions. And there are increasingly opportunities to share that information across the nation.
Yeah, I think that's right. And I think that some health departments have the flexibility and the ability to move faster than others. I think in Massachusetts, we're fortunate again because not only of the healthcare reform accomplishments, but because of the medical infrastructure. And so Fenway Community Health Center, which was one of the sites of the iPrex trial, is here in Boston. And so they were certainly one of the earliest adopters in Massachusetts, continuing people who had been on the trials. What we've learned from Washington State, for example, is that perhaps we need to utilize the infrastructure of our Ryan White-funded AIDS Drug Assistance Program to use state resources to support people who face cost barriers with PrEP. And that's something that we will be undertaking here in Massachusetts in the coming months, as we're very excited about that. But it really does involve partnerships between medical providers and community and the state health department to accomplish this. We have seen it as the ID, the infectious disease doctors, who are really taking the lead, but increasingly they as champions are pulling in their primary care colleagues and saying, this isn't so hard, it's not so scary, you can do this too. And that peer-to-peer work has been very instrumental here in Massachusetts.
It's so interesting because for so long we said at the very beginning of iPrex results, the first trial that demonstrated efficacy, that PrEP is not just a pill, it's not just a biomedical intervention. And it's so striking in what you're both saying that 6 years later we're still needing to recognize that it's not just a biomedical issue, it's a health systems issue, it's a behavioral issue as well. But I wonder, you said something very interesting, I wonder, Carl, to pick up on it about the way Fenway, for example, here, Dawn, was the kind of entry point, that interplay between research sites and implementation sites, so to speak. And I wonder, Carl, sitting at DAIDS and really overseeing one of the largest portfolios of the research agenda, that issue of the collaboration at a federal level, where research and implementers, CDC, HRSA, if you look back on the last few years, what's worked really well in terms of making sure results that you help support as a research funder don't end with the clinical trial?
Well, there's a couple of things we've been able to do is continue to push forward with pilots and different ways of rolling out PrEP. The other thing we have to keep in mind is the other key piece of the use of antiretrovirals for prevention is treatment as prevention. And I think that I would like to make sure that whenever we have a conversation about pre-exposure prophylaxis, we start from the point of HIV testing. Make sure that we realize that as people test negative and are at risk, we talk about a prevention continuum, but also not lose sight of the fact that we also have the care continuum. And the best way to help prevent, one of the best ways to help prevent HIV transmission is to get as many people on therapy and fully virally suppressed as possible. So that's the other key piece that we continue to really promote, and that has been a big step forward across the country, and that's part of the President's National HIV/AIDS strategy as well.
You know, I'm so glad you brought that up, Carl, because one of the things I think for me that was one of the most interesting data points of the CROI so far was actually Rafi Landovitz yesterday from UCLA presented data, and I can't remember the exact number. I think it was 7% of people who were on therapy and were virally suppressed thought they might not be infectious. And I'm wondering, you know, you're absolutely right. It has to begin with testing, getting people into treatment for who are infected, and getting people prevention options. What do you make of that number? And is there something that we need to be doing differently to help people understand what it means to be virally suppressed?
That's a really good question. I think that to a certain extent that people are so used, once they're HIV infected, to worry about transmission. In a way, it's healthy if people are cautious, so I'm not that upset by that. But I think having the conversation so that somebody who truly is virally suppressed, particularly in a discordant partnership, that there's an equivalency there, that then as long as people are open and honest about where they are in their therapy, I think we can deal with that. Because a couple of missed doses and you have a little bit of a rebound, it's over. So that's part of the message, is adherence is a day-to-day requirement for therapy as well as for PrEP.
And you know, it's interesting about adherence and relating to some of the things about both PrEP, and you mentioned the dapivirine ring. Young people, and you know, and it actually came up even yesterday in a treatment presentation, adherence amongst younger people on treatment, we have challenges. We clearly need to move forward across you know, treatment and prevention for all ages and all people at risk and all people who need treatment and care. But what do we need to do differently with young people, or do we just need to do more of what we're doing more intensively? I mean, what are we missing?
I think, first of all, you know, we live in the AIDS silo. Those of us who have taken care of young asthmatics, young diabetics, know that this has nothing to do with HIV. That young people just are not yet fully in charge of their lives in a way that lets them do a good job of taking medications regularly. And I think, first of all, we can look to those experiences, what has worked for other chronic conditions with young people. And then I think there is a lot of research going on about what kinds of extra things we can put in place, both for treatment and for PrEP, for young people to try to help them take their medications more regularly.
Dawn, you see that at a Massachusetts level.
Yeah.
So, you know, obviously we have the federal perspective, but when you look at the state, do you see big disparities around the age gap?
Around age, we do. And in fact, when we look at our Massachusetts care continuum by different population groups, if you break it out by age, you see viral suppression rises as people get older. So if you're over 60, you're doing really well. But those folks who are sort of under 25 are doing less well. And, you know, youth, as I've gotten older, the definition of youth has expanded quite substantially. So now we often
You're
talk
still
about,
young.
I'm still young. But we often talk about people under 30 now as being in that youth category, sometimes people under 25. And so when we look at the very young, the people who are sort of under 15, maybe some people who are perinatally exposed, obviously, they do very well because typically their parents or their guardians are so involved in their medication. But when we look at that group between about 15 and 25, even up to 29, they do have much lower rates of viral suppression. So we're asking them in community advisory groups and other areas about how do we need to modify the healthcare landscape for them? How can we make it more responsive? We're using many more peers on medical care teams, interdisciplinary care teams that involve mental health and other kinds of professionals other than physicians and prescribers. And we hope that will help, but also, you know, as regimens become more simplified, that's a big support as well.
You know, it's interesting that for young diabetics, you see exactly the same pattern, that when their parents are supervising their injections, they're doing fine. And between 15 and 25, they fall completely apart. and they have a whole lot more problems. What's also interesting is that there's a stigma involved in taking a shot every day, and they frequently try to hide it from people, and that interferes with the adherence that they need. So again, I think there are places that we can learn lessons about what works and bring it into the HIV arena for these young people.
It's so helpful because I think sometimes we attribute lots of results to a product when in fact what you're describing is much more about systems and people's lives generally. And I wonder, Dawn, you were just talking about hearing more from young people in the treatment setting. Carl, as you look out, having been a major investor in PrEP, in the ring, in vaccines, what should we be doing differently around some of the product development research activities? Clearly, it can't just come out of the laboratory. So what might we be doing to get that kind of input?
Well, if you think about how Procter & Gamble or any major company sells products, I think that it starts from a marketing perspective. And I think that as we roll forward in the future, starting with that kind of a target product profile that creates demand and desire in the youngest, whether it's the cool cell phone technology or linking it to something that they want in their lives, I think is going to be critical. I think biomedical strategies have never done that. I mean, you think about pills, we've always delivered medication orally, by a syrup, by pills, by injection, by suppository, by some means. We have to figure out how to package this differently, whether it's through films, where it's patches, or other means. We're going to have to really engage those groups. So whether it's Mattel or Apple, who can come in and advise us on how to create demand, how to create desire, I think that's the next wave. Because where we are right now works if you're over 25, if you are fully emotionally mature. It doesn't matter whether you're living in South Africa or Malawi or the United States, it's universal. And so that we really need to get to the level of bringing marketing into this equation.
Well, and it's so interesting because so often people think about bringing into marketing in public health after we have products. And I think what we now really know is that this adage, begin with the end in mind, and that has to be at the outset. And a good company wouldn't bring marketing in at the end of a product development cycle, but rather much earlier and even at the beginning of the cycle. So as we wrap up and get to the end of this, I want to talk a bit about the end. And there's been so much focus from the global conversation at UNAIDS, and including in the National AIDS Strategy here about ending the epidemic. Terminology that I'm still, many years later, amazed that we even talk about. And it really began in 2011, where we started saying, one could envision the end of the epidemic. I'd love to have each of the three of you just think for a moment, not what does the end look like and when are we going to get there, because I would never put anyone on the spot to say when are we going to really end this epidemic, but what should we be doing now in balancing the opportunities to think about the end of an epidemic, but making sure we don't oversell that end too soon and get people to think that we're done with our work, because we clearly are not. And I wonder, both at a policy level, in a research setting, in a state delivery system, how do we balance the possibility of the end of the epidemic with the urgency of the risk that you described of 1 in 2 lifetime risk? How do we balance this dynamic of opportunity but huge challenge?
I can start off answering that from the Massachusetts perspective, because we've been very fortunate here in that we do have a declining epidemic. We've had about a 41% decline in new HIV infections since the year 2000, but in the last 5 years, we've started to see a plateau. The initial data from 2014 looks like we've come down again, and we continue to see profound disparities. What's exciting in Massachusetts, for example, is in our 2014 data, for the first time ever, we had fewer than 30 HIV infections attributed to injection drug use. That feels like a getting to zero kind of a moment. And so we're utilizing successes like that to, one, call attention to the urgency of continuing our efforts, but two, to provide people with some hope that with some concerted joint efforts we can get there. Same thing regarding MSM, but in the opposite, that's the one intractable part of our epidemic where we're not seeing a sustained decline. And so it's led us to say PrEP is more urgent than ever. And so partly it's framing, it's engaging with populations, it's calling attention to disparities, and leveraging all the assets in our system. And that's how we're trying to get to zero to the extent we can.
Great.
From my perspective, we can make all the best innovations in the world, but if we can't implement at scale, we have a fundamental problem. So We're getting to a point now where we're starting to talk about PrEP implementation at scale, but with the next wave, whether it's an injectable or an implantable, we also have to be able to take it to scale. And at the same time, what we also need to be able to do is get different types of products for different types of people. A young woman in South Africa who's also worried about pregnancy as well as HIV infection needs a multi-purpose technology to protect more than one lifetime event, against more than one lifetime event. And should she want to get pregnant and not also and be protected from HIV, have a product that works in that manner too. So it's ultimately about best research, making better products, but then working with partners to make sure that we can implement to scale.
I think, as Carl indicated earlier, we're getting to the point with treatment as prevention where we really are getting closer to scale and closer to achieving the goals that we think we need. We're at the very beginning of that for PrEP, and I think trying to figure out what it looks like when it's all working is too hard for me. I actually can't figure that out. But I do think that we have an opportunity, particularly with PrEP, to do a lot of ancillary things as we're scaling it up that will outlast the need for PrEP. So getting young people linked to healthcare, getting their other conditions dealt with. You know, in the minority communities, for example, there's a lot of undiagnosed hypertension in young people. This is an opportunity to get that taken care of. Rethinking how we think about sexual health in general and getting people to think more broadly about their sexual health, and HIV is only a component of that. If we could accomplish that, we would be that much further ahead when the next issue comes up. So I think this issue of getting to scale with what we have now and being prepared to add on the things that are coming out of research is really benefits everybody. And somewhere along there, hopefully we'll get to the end of the epidemic.
No, I think that's great. You know, it's so wonderful because what you all really did in connecting any of these issues is recognizing that there is, you know, no one intervention, even no one disease that we need to be thinking about. It is about this comprehensive vision, whether it's about multiple options for both treating and preventing, or recognizing health systems have to deal with not just HIV, but so many other things. And, you know, it's silly to have to say it almost because it seems so obvious, but yet this idea that we're going to fix this somehow with one magic intervention is magical thinking, to say the least. And we've been hearing that, we know that all for many years, but it can't be repeated often enough that there's no single approach to this. And there's no single agency, whether it's CDC, NIAID at the US federal level, the State Department, the city health departments, who are really making huge progress. And not just about research or implementation, but bringing in the community perspective in both product development and product delivery. So this is awesome. We'll just end that. I just would love to get a quick one sentence. When you look ahead to, I guess it's February 2017, we'll gather in Seattle. We'll probably have a setting like this. What do you think is going to be on the collective field's mind February 2017? Or what would you like to see in 2017?
I would like to see that whatever is happening, we continue to pay attention to the disparities that have been highlighted here and elsewhere, which are profound in the United States. Yeah.
Great.
On the research side, we'll have a whole new raft of efficacy trials underway in 2017, both in vaccines and injectable prevention, and that'll be a very exciting time.
Great.
I think we'll see the first evidence of the impact of the scale-up of PrEP, and it'll be small and localized, but I think by next year we should have some data showing in the places where scale-up is going the fastest, what does it actually contribute in terms of reducing incidence.
That is I wouldn't even call that a wish list. That is a reality list to accelerate around both reaching impact, much more robust research agenda, and really addressing health disparities. So that's the agenda for the rest of this year and into 2017. So thanks very much, and we'll look forward to seeing you next year in Seattle.
Thank you.